Thank you, and welcome everybody. So, my name is Sean McGhee, as she mentioned. I'm one of the allergy faculty here at Stanford. Just started here in February, and I'm up here from UCLA, where I spent the first part of my career. I'm going to start today by telling you a story. I want to tell you a story about a friend of mine, some friends of mine, who actually have a very beautiful 2-year-old girl. Her name is Gabriella. And one evening, Gabriella went with her parents to a restaurant. And they wandered into the restaurant, and up until this point, she'd been doing quite well. She had no real major medical issues. She had a little bit of eczema and was wheezing a little bit with colds, but otherwise was actually doing very well. Went into the restaurant and happened to eat something with peanut in it. And eating something with peanut in it, about 4 or 5 minutes later, she all of a sudden started to vomit. And she's vomited once, and they thought, well, maybe there's just a little something going on. And then she vomited again, and again, and again. And at that point, they decided they couldn't really stay in the restaurant anymore. And not knowing exactly what to do, they bundled her into the car and hopped onto the 405, the busiest freeway in the world, full of traffic in the early evening hours. And stayed in the parking lot of a freeway for a good hour while they were trying to get home. So in that time, if those of you who know something about allergy might realize that's probably not the best response to take to someone who's having an anaphylactic episode. And yet, this is the first time she'd ever done anything like that. She'd never had a problem eating things before. And in the heat of the moment, lots of people do things that are maybe not what they would have done if they had time to sit back and think about it, or time to, or had an understanding ahead of time about what allergy really is and what it means. So she was vomiting. She vomited in the car. She vomited all the way home. The car, I would hate to see what that looked like at the end of it. So I guess the question that I have to ask is this a food allergy? So certainly there's a sort of coincidental timing. She did eat something that contained peanut, which is a well-known allergen. But even at the end of all this, they had given her some Benadryl, and she actually recovered and did fine after that. But they still weren't sure whether this was really an allergy or not. They called their pediatrician, and their pediatrician said, well, I don't know, I don't really think so. It doesn't sound like it so much. And then they talked to me, because whenever the question of an allergy comes up, people always talk to me. And so many people have allergies that I end up talking about this a lot. So of course, I'm giving you the story secondhand. I wasn't actually there, but this is what they told me happened. And yet, when you really stop and think about it, there's really very little doubt that there's an allergy. First of all, the child is obviously vomiting, right? So there has to be something going on. And if you think about the other things that commonly cause vomiting in children, like gastroenteritis or infections like that, they generally don't show up all of a sudden, bang, like a bolt from the blue, and they usually aren't that persistent right when they start off. So I think to me, it seemed like this was pretty likely that this was a food allergy, but I don't like to treat people that I know well, so I sent them to a colleague of mine, Maria Garcia-Loret, who's an allergist at UCLA, and she went and evaluated her, worked her up, and sure enough, in the end, we did prove that she had peanut allergy. So I tell this because a lot of people, when they're thinking about allergy and that, they look for hives or throat closing down or some of these other kinds of things that are very common. And I just wanted to point out that there's actually a very wide spectrum of things that can give you allergy and that are different types of reactions to foods and to other sorts of things. So I'm going to try and talk tonight about what an allergy really is and what an allergy isn't. And also try to go over some of the mechanisms and how allergies come about and what actually causes them, and what caused Gabriella's little event that night. So this slide here is basically an example of what happens when you have an allergy. So this is what was going on inside Gabriella's stomach when she ate the peanut. So at some point in her life, she had been exposed to something that either looked similar enough to peanut, or actually was a peanut, in some way that she had become sensitized. So And that's over on the left side of the slide there is sort of the sensitization process. But what we really care about, we don't really understand exactly how people become sensitized. What we really care about is that after that, she went on and the first thing after she became sensitized was that her T cells are kind of immune system cell. They're kind of the quarterbacks of your immune system. They're responsible for instructing your immune system what to do and instructing your immune system how it's going to respond to things. So those T cells there, over on the left side, just said, okay, I've seen something that looks like a peanut, and I'm going to send out all of these chemical messengers that tell the body to respond in a certain way. And in particular, they're telling that B cell there, which is one cell over there, that it's going to start making antibodies. And antibodies are proteins that are made by B cells to fight off infections. Ordinarily, they do a great job of fighting off infections, but there's a lot of different kinds of antibodies. And in particular, these T cells with the peanut started instructing the B cells to make antibodies of a specific type. And that type of antibody is called IgE. And IgE looks like this. You don't need to know this, it's all chemistry, but it looks like this. And the IgE there that is made by the B cell then goes over and it binds to this mast cell. The mast cell is the cell that's over there on the far right of the screen. So the mast cell then has all of this IgE sitting on the surface. And it's sitting there like a kind of trap. And it sits in your intestines, in your skin, and in your lungs, the lining of your lungs. And it waits there with all of these IgE molecules stuck to the surface of it. And it just sits and waits. And the mast cells can wait a very long time. The mast cells can be in your tissues for years, even decades, without doing anything. But if a little bit of peanut comes along, then all of a sudden, that peanut will bind to that IgE that's sitting there, stuck to the surface of the mast cell, and it'll bring those IgE molecules together. And once it brings those molecules together, that triggers the mast cell and tells the mast cell, now it's time to do something. And what it intends to do is respond to this as if it were a disastrous, life-threatening attack upon the body. So you can see down in the very right-hand corner, lower right-hand corner there, it starts to release all of these inflammatory mediators, all of these things that cause inflammation and that cause your body to respond as if it were under attack. And all of those inflammatory mediators, a large number of them are actually there preformed, ready to go before anything, they've been sitting there actually that way, like I said, sometimes for years. So if you look at these like scanning electron micrographs of or transmission electron micrographs of these mast cells, you can see them before they've got all these beautiful little granules in them. They're quite an attractive looking cell. And then after this, they just look like they've been hit by a bomb. There's nothing left in them. They release everything they have. So when they do that, all these inflammatory mediators come out. Once those inflammatory mediators are out, they now have a chance to cause the inflammation that they're supposed to do. They're actually just doing what they're intended to do. So the inflammation that they cause in the setting of an infection would be very helpful, but there's no infection here. There's just a little bit of peanut. So instead, what happens is this. So anaphylaxis is what happens when all of those mediators are able to get out, and instead of staying right around the mast cell, right where they are produced, there's enough of them that are released that they spread throughout the entire body. And once they spread throughout the entire body, now there's a kind of systemic reaction. So the entire body thinks it's under attack and is responding that way. In particular, some of those things are histamine, is one of the main mediators that comes out there, and that's the one that's responsible for a lot of those symptoms of anaphylaxis. Probably not all of the symptoms of anaphylaxis, but a lot of them. So and when you have all this histamine released, you get things like hives, vomiting and diarrhea, airway swelling. The histamine also makes all your blood vessels dilate. So all of your blood vessels open up, and it's as if you suddenly lost 3 liters of blood. And so your heart starts racing. Your heart starts racing to try and pump that blood through this space that's there that it has to fill up, that all of a sudden that wasn't there before. So all of this symptoms, as you can imagine, makes a person feel very anxious. When that blood pressure drops, you feel very anxious People start sweating. It's as if you're about to run a race or about to do something like take an incredibly important test. That feeling that you have where you're really nervous and your heart is pounding and all that. It's the same kinds of chemical messengers there that are making you feel like that. And this is what happened to Gabriella. So when the peanut antigen hit those mast cells in her intestines, they released all of those mediators, and all of that went out into the periphery, out into the tissues of her body, and caused this kind of reaction. Now, fortunately, it's mild enough in her. She did all right, and was able to be treated with just a little bit of Benadryl. But that's not always the case. These can be very severe kinds of reactions. And when you talk about fatal allergic reactions, this is the type of reaction that they're talking about. It's not the only type of allergic reaction that's out there, though. There are lots of kinds of allergic reactions, including things like hay fever, which is the more typical kinds of nasal allergies that most people think about when they talk about allergies. It's what everybody is suffering from right now if you're allergic to grass pollen or to tree pollen. It can, of course, just cause hives and nothing else, too. A lot of cases of hives come from this kind of reactions. Asthma itself is not an allergic reaction, but certainly can be triggered by allergic reactions. And the same thing with eczema. Again, not itself an allergic reaction, but can be triggered by allergic reactions to foods and to other antigens. So we know that Gabrielle had a reaction to a peanut. But what kinds of other food allergens are there, and how do we know that she's not going to react to something else? So the other thing to think about, too, is that, of course, if you think about the dish of food that she ate, there's lots of things in there, right? There's oils, there's wheat and the pasta, if it was a kind of pasta thing that she was eating, all kinds of stuff in there. So how do you tell which one is what she's actually allergic to? Peanuts certainly sounds like a major culprit, but how do you know it wasn't even like, pepper or something like that, right? As it turns out, if you look at all the different things, all the different foods that cause allergies, 95% of food allergies can be boiled down into these 8 different types of foods. So if you look and really do a careful study, find out exactly what is responsible for people's food allergies, 95% of the time it'll be one of these 8 things. In addition, some of these things tend to affect children more than adults, so you can kind of even get a better idea by narrowing it down to the right age group. So egg, milk, soy, and wheat, peanuts, tree nuts, because peanuts, of course, as allergists are fond of pointing out, are not a nut, they're a legume. And tree nuts, fish, and shellfish. Again, because a fish actually is not actually that closely related, evolutionarily speaking, to a lobster or a shrimp. So they actually do tend to be different, and just because you're allergic to one does not necessarily mean that you'll be allergic to the other. So, in fact, we don't need to go through and test the whole range of possible things that might have been in that dish. It's conceivable that she was reacting to something other than the peanut in there, but since we got like a 95% chance of hitting the right one just by testing these, we can actually try and focus on these first, and then if those don't pan out, then we can look elsewhere. So once we know that these are the most likely kinds of things, then we can go and perhaps do some testing. And testing is one of the things in allergy that is not very well understood all the time. And one of the things I'd really like to get across to people is what testing for allergies can do and what it really can't do. So I'm going to put up, I kind of divided the main tests that we use for allergy into 2 different kinds of categories here. So I already talked about IgE and how important IgE is to this kind of reaction, right? So there's 2 kinds of tests that we have that test for IgE. And they look for IgE that is made and that is specifically reactive to those particular things that you're interested in, say the peanut, for example. So the skin testing is one. This is where we take drops of things that you might be sensitive to, put it on your back or on your arm, and just scratch the surface of the skin just a little bit so that that antigen can kind of get down in there a little bit. And it's a nice, safe way to see if somebody is actually reactive to that sort of thing. And that reaction, which looks like a little hive when you get it, tells you that there is specific IgE specific for that food in that little area of the skin. So then you know that somebody has specific IgE to that food. RASTs, or the immunocap assays, are actually blood tests. So these are the allergy blood tests that people sometimes talk about or get, or there's even talk, I think, about letting you get them from Costco if you wanted. The ImmunoCAB assay it's a handy test because you can just go and have your blood drawn. You do have to wait a bit longer to get the results, but in essence, it's measuring exactly the same thing that the skin testing is measuring. It's just getting at it by a slightly different route. Both of those things are after how much specific allergic antibody is there that this person is making that is responsible or that could be contributing to this allergy. Now, one thing that you really want to pay attention to here, though, is that when we're talking about IgE, you're only talking about one part of that allergic reaction, right? Now, I told you the mast cell is all covered with IgE, so that IgE kind of has to be there for this allergic reaction to happen. But suppose you didn't have very many mast cells around, or suppose that the antigen couldn't really reach the mast cell even if it was all covered with IgE. So there's a lot of things that actually have to happen that are not just the IgE to make an allergy. So in that circumstance, it's possible to have some IgE around, but still be able to eat things as long as, sort of, say your intestines are good enough at keeping that antigen inside the middle of the intestine and not getting out into the tissues. Then you're not going to have an allergic reaction even though you've got specific IgE around. So because of that, you have to do another kind of test. And this is the test to see whether somebody is actually clinically reactive, whether when exposed to the food or the pollen or the antigen that they think that they're allergic to, if they're actually exposed to that, do they actually have an allergic response that matters? And so that kind of testing that we do is called challenge testing. So that's I'll tell you that one of the first things parents sort of discover when they think their kid might have a food allergy is challenge testing. They're like, well, let's give them a little bit more and see what happens, right? So we do that, and that is a valid way of trying to figure out. But we have a very specific protocol for doing it. We have a very careful way of doing it, and we do it in a setting where we can treat any significant reaction that occurs. We're also very careful about how we dose it and how we give it to somebody so that if they do have a reaction, they have a relatively mild reaction. So this is one of those things that it's great. It's actually critical for determining who truly has a food allergy or not. But kids don't try this at home. So we did some specific IgE testing for Gabriella. And this isn't actually her results, but it's kind of what you might see. And this shows you those results of both the skin testing and the ImmunoCAB. In this case, they agree. They don't always agree because they are different kinds of methodologies. So that's part of what we have to do as allergists is interpret this and figure out what's really going on. But the skin testing, we look at and we measure how big of a reaction you have. It's really just that simple. So if you don't really have any reaction to milk, egg, wheat, soy, none of those things, but boom, you have 14 millimeters of a wheal to peanut, then we know that you've got specific IgE to peanut there. Didn't have any reactions to almond, which can happen. You can be, again, remember, sensitized to peanut, but not to other nuts. And then we also have two things on the skin test that we use as controls, things that let us know the test is working. And that includes the histamine, which is something that everybody should react to, right? Because that's basically, we're putting that pure chemical mediator on your skin that tells all of this kind of reaction to happen. And then the saline, which is just salt water, so you should get no reaction to that. So it lets you know what something that's truly negative looks like, and it lets you know what something that's truly positive looks like. A lot of times you'll see people who are very sensitized to particular foods will have a skin test reaction that's actually bigger than the histamine, and that's not uncommon. And she, in fact, has something like that. The ImmunoCAB is the blood test, which we often send in food allergies in particular, not so much in other kinds of allergies, but in food allergies because the nice thing about that is it gives us a very specific number, and a specific number that's kind of reproducible from one lab to another and one day to another and 1 year to another. So it gives us something that's a little easier to follow over time. If you're just looking at how big a reaction is on somebody's skin, sometimes people's skin may be a little more reactive one day, a little less reactive another. So this lets us figure this out sort of on a more hard and fast kind of basis. And again, you see she's got negative results to everything except the peanut, which was very high. The other thing that the ImmunoCAB assay allows us to do is that researchers have figured out specific cutoffs at which you can say, if you're above this level of peanut-specific antibody, then we know that there's a really good likelihood that if you take an oral challenge and we give you some peanut, that you're going to react. So if you're above this level, which for peanut happens to be about 7, If you're above that level, then we don't even have to do a challenge because we know it's really likely that you're going to react. Unfortunately, if you're below that level, we can't say that you're not going to react. So that's another important thing to remember about allergy testing is when it's really positive, it does tell you something, but when it's only a little bit positive, you still have to do the challenge. So here's another important thing to take home about allergies and food reactions in general, and that is that there's a lot of different kinds of food reactions out there. It's not all just allergy. So a lot of times people use the term allergy to sort of refer to anything that's a kind of bad reaction, something bad that happens to you when you eat something. But in fact, the IgE allergy, which is what we sort of consider a true allergy, that's only one of these kinds of food reactions. There's also a bunch of different kinds of irritant reactions. There are enzyme deficiencies like lactose intolerance, and a bunch of other things that have nothing to do with IgE, and yet are still bad things that happen to you when you eat a food. So it's very important to recognize this, and we're not just trying to be pedantic when we say, okay, well, that's not an allergy, that's a food reaction. And the reason is that distinguishing what's caused by IgE is really important from a clinical standpoint. Because, for example, most of the other reactions, not all of the other reactions, but most of the other kinds of food reactions are self-limited, meaning when it happens to you, you may be uncomfortable for a little while, but you'll get better. So you're not going to die. Whereas with IgE-mediated reactions, there's actually a chance that you could have a very severe and potentially fatal reaction. So that's one reason it matters. The other reason it matters is that all of that testing I told you about, except for the challenge, right? All of that testing was for specific IgE. If the kind of reaction that you're having has nothing to do with IgE, then measuring the amount of IgE you have is not going to be very helpful. So that's another reason it's important to distinguish between things that are quote-unquote true allergy and things that are just food reactions. Finally, if you test a lot of things, say, a lot of times allergists are guilty of, doing millions of tests to different things, because a lot of times that's what people want them to do. If you test lots of things that are not likely to be actually causing the reaction, then you're likely to get a lot of false positives. And you're going to spend a long time chasing down all of these false positives before you figure out what's really going on. So that's why it really is important to make this distinction between what's caused by IgE and what's caused other kinds of food reactions. It's not that those other kinds of food reactions aren't significant or aren't important, but it's that we have to treat them differently, and the testing that we do to figure out what's going on there is going to have to be different because it's a totally different mechanism. And this is just kind of what I already told you about, but the predictive value positive basically says that when you test in populations where there's not much disease, it means that most of the positives will be false positives. Very important with allergy testing, especially if you're going to do a lot of different tests. You run the risk, every additional test is going to run the risk of getting a false positive. And all tests will perform better when there's a higher likelihood of disease. So that's why it's not the Costco method of doing skin testing or allergy testing is not so good, because you're going to run the same panel on everybody. Whereas it's much better to talk with people, get a sense from people what's really going on when they eat different foods, and then you can target your skin testing so it'll be much more informative and much more likely to be accurate. So then how do we tell sort of what is an allergic reaction and what's not? That's part of why I'm here. That's part of what I do. But in general, one of the things I'd like to share with you about allergic reactions that are truly allergic reactions is that, one, they tend to be rapid. So like I mentioned, Gabriella had her reaction within 5 minutes of eating the food. Almost all of these anaphylactic reactions happen within 30 minutes, and you capture virtually all of them within 1 hour. So it's very unusual to have, say, a true allergic reaction occur many hours later. It's been described, but doesn't happen very often. So, and if you remember that makes sense, because that mast cell is sitting there, and it's already primed and ready to go. It's got all those mediators in it, and it's ready to just degranulate and send all those mediators out the very instant it encounters the peanut allergen. That's its whole point. It's there to be a rapid response system. So most allergic reactions happen very rapidly. And in fact, the more rapidly they happen, the more likely they are to be serious and fatal. Second point is that allergic reactions tend to be reliable. Meaning, if I give you the same amount of peanut on a different day, most people tend to react at about the same measured amount of peanut, regardless of what day it is or what have you. So as long as you're getting the same amount of peanut by the same route, then you're going to have the same kind of reaction. Allergic reactions for most people also tend to be kind of stereotyped, meaning that if you have a kid who tends to get vomiting like Gabriella did when she eats peanut, that's usually what's going to happen the second time, and the third time, and the fourth time. Hopefully they don't have that many times. And then, of course, allergic reactions have IgE present. So almost all the time, occasionally there are false negatives on our skin testing and our immunocaps, but most of the time you will find that specific IgE there when you do the testing. So all of that helps us narrow in on the fact that this reaction is in fact allergic and not one of the many other kinds of food reactions that are out there. So that then brings us to the question of, all right, now that we can kind of figure out what thing may be causing the allergy, now we're left with what can we do about it, right? So when I think about what can we do for allergies, I'm reminded of this famous old joke about the guy who goes in to see his doctor, right? And he says, "It hurts when I do this," right? So don't do that. That's basically what we have to offer right now for food allergies. It's different for other kinds of allergies, but for food allergies, this is kind of what we have to offer. So the main things that we do when we see somebody in the clinic for a food allergy, these are the 4 things that I want to take care of when I'm seeing a patient there. And one is that identification. That's kind of what I've been talking about before. I want to be able to identify exactly what the antigen was that's causing them a problem, because I'm not going to be able to educate them very well. I'm not going to be able to teach them how to avoid it unless I can really carefully and accurately identify what really is the problem. Many times, that means that you have to do a food challenge. Not always, but sometimes you do. So we do a lot of food challenges at Stanford. We bring people in and we have them eat foods in our clinic. Every Monday, you'll see kids sitting there eating chicken or peanuts or something like that to see if we get reactions so that we can identify who really has a reaction or not. The second point that I want to do when I see somebody in clinic is educate them, because there's a lot of misconceptions about allergies, and I want to be able to have a chance to address that with people. So that's the other thing that we do in treatment that I actually think is really important, is teaching people not only about the nature of their allergy and what they need to do to manage it, but also, how do I avoid these foods? Where am I likely to find them? Where are they likely to be hidden? How do I read a label to figure out what is really in these foods or not? Finally, we want to give people emergency management plans, so we want them to have something to do if they do accidentally get exposed to a food, because nobody's perfect. Even the most meticulous parents or patients will occasionally run into something that they're allergic to. It may be hidden from them, maybe they didn't know about it, and so they need to know what to do when that happens. And then finally, monitoring for resolution. This is what another thing that is often misunderstood about allergies is that a lot of times people think that once you have an allergy, you have it for life and it's never going to go away. And in fact, that's not really the case. For most children, most of those food allergies with those antigens I talked about beforehand will actually resolve. So the peanut and fish and shellfish allergies are ones that tend to last a little bit longer. But even peanut allergies, which most people really do think you keep for life, at least 25% of people will actually outgrow their peanut allergy as well. So it really is worth continuing to monitor people and check those levels, and I'll tell you a little bit about how we do that. So identification, I already talked a little about this. We want people tested, we want them challenged if we need to, and we want to help people interpret those results. So again, very important. Education in particular, so again, don't do that. Food avoidance and reading labels so they recognize it. Another thing that we often do is have, especially with children, is have them seen by dietitians so that we can figure out whether the number of different kinds of foods that they may be avoiding is actually impacting their nutrition and their growth. So this is very important as well. Again, all part of education. Management plans. Part of the emergency management plan is recognizing when your kid actually is having anaphylaxis. So that would have been very helpful to Gabriella's parents when she was sitting there vomiting. If they knew that in fact she was actually that was actually an anaphylactic event, they would have known what to do about it then. And what do they do about it? You give epinephrine. So epinephrine is actually, so epinephrine is one of the most important drugs we have in the management of allergic reactions. And the point about epinephrine is that you want to give it rapidly. So in general, when I counsel people about this, occasionally there are people who tend to have reactions that unfold very slowly, and they tend to only get skin symptoms initially, and they've got some time. For those kids, I think it's okay for them to have some Benadryl and see how they do. But for anyone who has got more severe symptoms than that, you don't want to wait. And one of the things is, so if you look at fatal anaphylactic reactions, who's actually died from anaphylaxis, one of the things you'll notice is that only 7% of the people who died from anaphylaxis have hives. So why is that? In fact, if you look at all anaphylaxis, hives are one of the most common symptoms. Not present in every case, as Gabriella showed, but it is present in most of the cases, over 70%. And yet only 10% of the fatal cases had anaphylaxis. So why did those cases die? They died because they weren't recognized in time, because people were looking for the hives to see the hives appear, to let them know that there was anaphylaxis there, and they never came. So that's why it's important to recognize that hives can be there, but not always. So this is the kind of education that we need to do with people so that they understand what they're looking for in these kinds of circumstances. We also need to teach them how to give the epinephrine, since it's an injected medication. And we also need to teach them that they need to carry it around with them, because if you don't have it with you, you can't very well give it. And then finally, we need to even assess people's living situation and see, sort of, for example, how far do you live from a medical center? Because if you need epinephrine, the epinephrine is only good for about 15 minutes in your system, and then you need another dose. And so it's possible if you had a very severe reaction and you live 30 minutes away from the nearest hospital, that you need 2 EpiPens and not 1. So these are all the kinds of things that we'll go over when we... And then finally, monitoring. Like I mentioned, because kids grow out of these things, we need to do regular testing. And for those early food antigens, the egg and milk and wheat, soy, those kinds of things, I actually test every year to see if that specific IgE level has fallen down below 2. Below 2, you've got a 50% chance of passing a food challenge if you give it. So in that case, it's worth actually giving them a challenge to see if they've outgrown the food. This can be really important for some of those more complex food allergens like wheat. Try avoiding wheat sometime from your diet, and you'll see that it's actually pretty hard to stay away from wheat. So when we can liberalize kids' diet that way and let them eat more kinds of things, life becomes much, much easier for parents. And so that's a real blessing for them. So then, what about desensitization? I told you there was really nothing we could do except avoid foods. But if you've been following the allergy world recently, you'll know that there have been some trials recently using desensitization, where you actually give people a very small amount of peanut, and then you give them a little bit more and a little bit more, and you advance that up until you get to as much as you can make them tolerate. And when you do that, you can actually get people to tolerate a fair amount of peanut, but they have to keep taking it over time, and you have to, and there is a risk of reactions, of course, doing that therapy. The trials that they've had for this have actually been quite successful. You are able to get people to tolerate quite a large amount of peanut by doing these trials, but it's not a full typical dose of peanut. So for example, you can get people to tolerate an accidental exposure worth of peanut, but you generally don't get people to tolerate a peanut butter sandwich worth of peanut. So in that sense, it's not that helpful for somebody who just wants to say, okay, well, I want to be able to have a peanut butter sandwich. Desensitization is not going to help you. But if you're the kind of person who has anaphylaxis to a very small amount of peanut, and going into a restaurant makes you feel like you're taking your life into your hands, then actually doing a desensitization protocol like this might be very helpful. The problem, though, is, like I mentioned, it's changing that threshold at which you react. It's just making you react at a much higher dose of peanut than you did before. So it doesn't eliminate your sensitivity, and you're not necessarily going to be able to go and have the peanut butter sandwich whenever you want. These are very new. Too as well. So you need to be someplace where they're actually doing this as a research study. Not a good idea to sort of like try and wing it offhand. We do have a research protocol at Stanford if somebody's interested. But as I mentioned, this is really primarily restricted to people who have very dangerous, life-threatening types of peanut allergies or other food allergies where avoidance is really just about impossible for them. But for those, it actually can be quite helpful. But again, you do have risks of reactions, and so it really needs to be something that you consider very carefully and talk over with the allergist. So I want to talk briefly. So why does Gabriella actually have this reaction to begin with? So why did she actually go down this pathway where the T cell told the B cell to make this IgE antibody? Her predisposition to doing that is what we call atopy. And atopy is basically just, it's an old term in medicine, and the term just means the predisposition to developing allergies. So it means you're the kind of person who's likely to get an allergy. That means people who are like that tend to have a lot of other problems as well. You often have eczema. We already talked about food allergies. You have hay fever, nasal allergies, and you can have asthma as well. All those are part of this atopic condition. And it turns out that when babies are born, they are all naturally kind of in this kind of atopic predisposition. That's why people have, that's why these food allergies and things are much more common in infants and young children than they are in adults. But most people actually lose that, and they start to switch from making that allergy type of response to making a more normal kind of immune response later on in their life. But some people just seem to be slow at making that switch. And that's exactly what happens and why they develop atopy. These different components, eczema, food allergy, hay fever, asthma, tend to develop at different ages. So you have eczema early on. When you're an infant, you often go on and develop food allergies kind of closely after that. Hay fever when you're around maybe 4 or 5 years old, and then asthma when you're around 6 or 7. That's a typical sort of progression for people to make if they actually have all of these different features of allergy. And that's been given the name the atopic march, because basically no matter what you do, people seem to march down this pathway to developing these different things. But that said, you can grow out of allergies, at least food allergies. You don't grow out of your atopic predisposition, but you do grow out of these allergies. Most of the food allergies do resolve, usually by the time you're around 4 or 5 years old. But the peanuts, tree nuts, fish, and shellfish are less likely to resolve. Interestingly, there's also kind of an order in which these tend to resolve as well. If you've got multiple food allergies as an infant, for example, the egg tends to resolve first, and then you resolve your wheat, milk, and soy allergies, and then peanut is usually the very last to go. Another interesting thing is that it turns out you may tolerate cooked foods before you can tolerate raw foods. And this is very common with the egg allergy because egg is in lots and lots of things, but it's often thoroughly baked into cakes and cookies and those kinds of things. And we'll often find that a kid can tolerate the baked egg long before they can tolerate a scrambled egg. This is also important because I've also seen people try and do challenges, and they do a challenge with a hard-boiled egg, and then the child goes home and they have anaphylaxis because they try to eat a scrambled egg. So important to be aware of that, that little thing as well. And then the way I follow this is by monitoring that specific IgE level on about a yearly basis and seeing when we can re-challenge the kid. So we talked about the atopic march. So what's in Gabriella's future? Well, possibly hay fever, which is what a lot of is the main allergic problem for a lot of adults. So the term we use for this is rhinitis because hay fever technically was invented to refer to pollen allergies, but there's other things that cause the same kinds of symptoms besides pollens. And generally, these are the inhalants, and these are the major allergens. So kind of like food allergy, there's a relatively limited subset of things that actually cause true respiratory allergy. It includes pollens from grasses, weeds, and trees. It includes dust mites, actually the feces from dust mites, which are tiny insects that tend to live in mattresses and things and feed off of shed skin cells from people. Cat is a huge inhalant allergen, and cat antigen turns out is everywhere, even in places that don't have cats. And finally dog, though dog is less allergenic than cat is. So I talked so long about food allergy because a lot of the same principles, the principles surrounding testing and that applied to inhalant allergies as well. There are a few important differences, but a lot of them apply. For example, there are other causes of rhinitis besides allergy. And so if you have, you may have rhinitis from irritants. You can have rhinitis from chemicals. The people who tell you, I can't tolerate Christmas trees, I can't tolerate, fireplaces or chemicals, newsprint, those kinds of things. That's actually not a true allergy, as I mentioned, because it's not caused by IgE. It's a different kind of reaction that you're having. So again, you have to be careful because that's not going to be tested for in our allergy testing. Your testing should be targeted, just like you do the targeted testing for foods. If you can avoid testing for everything under the sun, then you're much better off because you're much less likely to find false positives. And the treatment principles that we have are similar as well. So how are we going to then narrow in on what's actually causing your hay fever allergy when we talk to you in the clinic? Well, one of the big things is this question of seasonality. So the nice thing about pollens is that even in California, pollens tend to come at certain times of the year. If you have a lot of different pollen allergies, and especially in California, you can kind of make it a long way through the year. But eventually there should be some time in the year when you're actually doing better. Over on the East Coast, the seasonality with allergies is much more pronounced. It's just that the weather is so mild here that we get a lot more pollination. But on the East Coast, that's why they have a very compressed ragweed season, and everyone knows exactly when ragweed is pollinating. Not quite as obvious here, but you still do see the seasonality for most people when they have pollen allergies. If you've got other kinds of allergies, though, the indoor allergens, then of course those are not going to change as much with the seasons. The amount of dust and dust mite that you have in your house is not going to change with the seasons generally. And also you're not going to have, if you have a cat, that's not going to change with the seasons either. Some of the really key pollens in the Bay Area, the big ones that are a problem for most people, grass is a huge issue in the Bay Area. There's a lot of grass pollen around. The grass is the one that causes the typical classic hay fever symptoms. But another very important allergen in the Bay Area is oak. And so if you're wondering what was bothering you right now, it's probably the oak. In addition, there's olive and ash. Olive and ash they're two different trees, but they're similar enough that people who are sensitive to one are usually sensitive to the other. And so an interesting thing happens with this pair is that olive is the one that tends to be much more sensitizing. So people get exposed to olive and they get sensitized to olive. And then, but olive doesn't actually produce that much pollen. You can find it in pollen counts, but it's not that high. What really produces tons and tons of pollen is ash. So, and ash was what was responsible. If you're having trouble in February of this year, that was probably the ash that you can thank for that. So people get sensitized to olive, but they react to ash. And then mulberry is the other thing that's active right now, and juniper and cedar are also big ones that we have in this going on right now. The indoor antigens, I mentioned, symptoms with these are year-round. And in particular, you want to pay attention to cat and dust mite. These are things that a large percentage of people who are atopic and sensitized to things, they have, are sensitized to cat and to dust mite. So dust mites are a little bit easier to avoid because you can put covers on your mattresses and do things like that to not be pressed up against dust mite antigen quite so much. Cat is a little bit harder to avoid. Though, of course, you can always get rid of your cat. Most people, however, if they already have a cat, are not so interested in getting rid of the cat. And the old joke is that they would rather get rid of the allergist than the cat. So how do we manage the rhinitis symptoms? Just like foods, one thing you can try is avoidance. The difference with foods is that while it may be difficult to avoid peanut, it's not impossible. You can try to avoid peanut, and you can probably get through most of your life without ever eating a peanut. However, it's a lot more hard to avoid grass pollen. It can come from miles away. You can try and cut down all the oak trees in your yard, but it'll still just blow in from somewhere else. So you can close all your windows and run your air conditioning year round, but even then, you're still probably going to get some pollen there. Avoidance is much more difficult with these things. So then you're stuck with trying to either manage the symptoms or to desensitize somebody. So symptom management basically just means using medications. We have lots and lots of different medications available, and you can usually find some combination of medications that will keep most people under control. That's not always true right when they get right in the middle of the season, or when if you decide to keep your cat despite that, you still may have symptoms because there's just so much antigen around. But generally, we can make people feel pretty good with their symptoms alone by managing their symptoms with drugs alone. But a lot of people don't like to take that many medications. So sometimes to really get somebody's symptoms under control, you're talking about a couple nasal sprays, doing sinus lavage where you rinse your nose with saline a couple times a day, and are on medications you take orally. And even then, you still might have some symptoms. So what do you do about those people? Those people, in contrast to peanut, where I told you desensitization is available on a kind of research basis, here, desensitization is actually very well established and has been around for a long time. In fact, the desensitization protocols were actually the very first therapy that we had for allergies. Developed long before we had antihistamines or any of these other medications to use for them. So the desensitization is what most people refer to as allergy shots. And you start out with a very low dose of the allergen. Each set of allergy shots needs to be designed for the specific patient who's receiving it, because you need to have those specific things in it that that patient is sensitive to. If you give them things that they're not sensitive to, you're not going to do them any good whatsoever. So it has to be specifically designed for each individual patient, and you gradually build up over usually about 6 months or so to get to a point where they reach a maintenance dose. After that, you can space it out to about once a month, and after about 3 years of that, you can usually stop them. There's another old joke about it's a guy who goes to his allergist and is talking to his friend, and he says, "Well, I finally quit my allergy shots." And the guy said, "Well, are you all better?" And congratulations. He says, "No, I'm not all better. My allergist died." That's actually not the way it should be. In fact, you should be able to stop your allergy shots after about 3 to 5 years. And most people, but not all, but most people will have a permanent resolution of their symptoms. It is important, though, that the allergy shot regimen is carefully designed, and you have to have a good dose of the antigen in it. In the older days, there were a lot of times people were trying to do desensitization with doses that were not low enough. So a lot of people who had allergy shots in the past and didn't really get much benefit from them may have had a dose that was just simply too low. It is also important to remember the whole thing I was talking about with IgE, right? Because again, if you've got this other kinds of rhinitis, other kinds of nasal inflammation, allergy shots are not going to be helpful for you. So again, still very important to make that distinction that seems pedantic between what is a true IgE-mediated allergy and what are other kinds of reactions. So prevention of allergy. So what can we do to prevent Gabriella from having future problems? You will notice this slide is blank. That's because there really isn't much right now. This is one of the most active areas of research, but there's nothing really established that will really prevent allergies. In fact, some of the things we thought we knew, we now know that we don't know. There was a lot of emphasis placed for a long time on avoiding foods early on in life, because the thought was if you didn't eat peanut in the first year of life, then you wouldn't have a peanut allergy. Turns out not to be the case. If you avoid cow's milk in the first year of life, you wouldn't have a cow's milk allergy. Turns out not to be the case. And in fact, it might even be that being exposed to those things in kind of low doses orally early on might actually be protective. But again, we've been burned that way before. So the bottom line is we really just don't know. So what I advise people right now is that I don't make any specific recommendations. If you want to give your child cow's milk formula or cow's milk early on in life, that's okay. Breastfeeding is still best, but you don't need to make those decisions based on avoiding food allergy. So one of the things that goes into the prevention of allergy is trying to figure out how allergies develop in the first place. If you knew how allergies developed, then you would be able to maybe design something that would prevent them from developing. So this right now is our best thought about why allergies develop and why some people make this kind of slow switch from making an allergy kind of response as an infant to making a more normal adult kind of immune response. And It's called the hygiene hypothesis because it evolved out of these observations that occurred when, mostly in Germany actually, when East and West Germany were separate. And you looked at rates of allergy and asthma in West Germany and East Germany. You found that East Germans, which were living in a much more sort of a dirty environment, and so there was a lot more sort of pollution. The idea was it wasn't as sort of clean, Western kind of environment. And in that case, but they had a very low rate of allergies and asthma. But if you looked at West Germany, they had a much higher rate of allergies and asthma. And when the two merged, the interesting thing was that standards of living in East Germany came up to meet the standards of living in West Germany, and so did the rates of allergy and asthma. So all of a sudden, East Germans were having the same incidence of allergy and asthma as West Germans. Other studies that have looked at this have found, for example, that if you look at kids in cities, they're a lot more likely to get allergies and asthma than kids who grew up on farms. And if you look at farms, kids who grew up on vegetable farms are a lot more likely to get allergies and asthma than kids who grew up on animal farms. So there seems to be something about, that if you grow up in a horse stall, that you actually tend not to have allergies. So right now, the only thing we can suggest is that you go and live in a horse stall, which, maybe not everybody wants to do because there's a lot of other reasons to avoid that. But as far as we can tell, this is the main thing that is protecting people against the development of allergies and asthma. And the more recent thinking about this is that exposure to all these different bacterial products actually reprogram your immune system. So basically, it's giving your immune system something to do. And so if you don't get that kind of reprogramming to make that response against bacteria, then your immune system is bored, idle hands are the devil's work, and they start making allergy kinds of responses. So that's Gabriella's story. And I'd just like to finish up by saying that she is actually doing exactly what we talked about. She's avoiding. She is seeing her allergist once a year and doing just fine. And so I would like to thank you all for coming and to be available here to take any questions you might have. And allergy is a big topic. I covered only a little tiny fraction of it, but I'm happy to talk about anything that you're interested afterwards. Thank you very much. So the question was, what other kinds of triggers do you have for rhinitis other than allergens? And if you do have those other kinds of that other kind of rhinitis, how do you figure that out? So it is also more complicated by the fact that you can actually have both kinds of rhinitis. You can have allergic rhinitis, and you can have non-allergic rhinitis as well. Sometimes it's very easy. Say, for example, we have somebody come in, they're complaining of rhinitis symptoms, and we do allergy skin testing, and they just have nothing. They don't seem to be atopic at all. Those people, it's relatively easy, because if you don't have IgE, you don't really have a true allergy. But you do have these, but you can, of course, have all these other kinds of rhinitis. With those kinds of rhinitis, I usually talk with people. There are some specific kinds that have been described. For example, vasomotor rhinitis is one where people have often complained of triggers such as perfumes, strong fragrances, newsprint, Christmas trees, firewood, fireplaces, ash, those sorts of things. If those are the kinds of things that bother you, it's probably vasomotor rhinitis that's causing your symptoms. There are other people who have something called chronic rhinosinusitis, which is it's kind of a chronic inflammation of the nasal lining. In a way, I kind of think of it as like a gingivitis of the nose, right? So you don't really, nobody really knows what causes gingivitis. You get swelling and inflammation in your gums, and that same kind of thing can happen in your nose. You have a kind of chronic bacterial film there, and you get some swelling and inflammation there that persists. There are several other causes of rhinitis too, and those are all things that that we need to think about when we're evaluating somebody who's coming in with those symptoms. People can have hypothyroidism that can lead to rhinitis. Even just pregnancy alone can lead to rhinitis. There's a very famous rhinitis of pregnancy. So there's a lot of different things that can cause it. The two major things I would say are that vasomotor rhinitis, where it comes from fragrances, strong odors, perfumes, those kinds of things, and allergic rhinitis. But again, these things can coexist too. So we really have to take a comprehensive view and think about, the whole patient that you see in front of you. The question is, if you say, for example, if you have noticed that you react to cat and you drink milk afterwards and you notice that it gets worse, I think you would need to think carefully about whether sort of, a lot of times when you're, say you react to the cat and you, particularly with cat, people will often kind of get cat antigen on their lashes or on their fingers, and then sort of unthinkingly maybe rub their eyes, and that kind of, then basically increases their exposure, even though the cat may not be directly around anymore. So I think you need to think about whether, it's just sort of the time and getting the glass of milk and drinking it that you had, that you gave yourself more time to kind of rub that antigen into your eyes or something like that. I can't think of a clear mechanism why it would make the itching and that kind of thing worse. But it could be the sort of the general timing of things, and with that you could do your own little controlled study if you wanted to and see if it really is just a timing question or if it does in fact have something to do with the milk. It'd be interesting if it did have something to do with milk, but I can't think of how it would actually work. So if you have an IgE-mediated milk allergy, so if your milk your milk allergy is a true milk allergy and not some other kind of intolerance or something like that, in general, unless you heat the milk somehow, either bake it thoroughly or cook it, then you're not so likely to have. If you heat the milk thoroughly, then sometimes people can tolerate, like I mentioned with the egg, sometimes people can tolerate a baked egg when they can't tolerate a raw egg. If you heat the milk really thoroughly, and that means more than pasteurization, it means really thoroughly baking it or baking it into something or something like that, then sometimes people can tolerate it. In general, the problem with the IgE is that the IgE is recognizing a protein. And that protein is the same if it comes from a cow that ate organic grass, organic fodder, or a cow that that was raised in the worst kind of factory farm imaginable. So in general, that's not going to change that kind of antigenic structure of the milk. So for those in that circumstance, if you truly have an IgE allergy to milk, switching milks probably like that probably isn't going to help you. Now, it may help you with other kinds of, if you have a different kind of reaction. Like a lot of people with lactose intolerance may be able to tolerate some milks and not others, and that sort of thing. But then again, that's one of these other kinds of reactions, a little bit different than allergy. We do work people up for those kinds of things as well to try and figure out if those are responsible. But in general, switching the kind of the farming practices and the raising practices, good idea for other reasons, but it's not necessarily going to help you with the allergy question. Oh, would it help to prevent them from developing additional allergies? Yeah. I haven't seen it make a lot of difference. So a lot of people do try to switch that way. I think there are nice reasons to eat organically and to go with foods that are as little processed as possible. But I have not noticed that it makes a big difference in whether kids develop allergy or not. And I think that's just because a lot of that question of how you develop allergy, if you think about it, is driven by things that are internal to you. You have an atopic predisposition, or you don't. And there's certainly an environmental trigger that comes in there, like I was talking about. Growing up on the farm, you tend to do a lot better with allergies and asthma than you do if you're growing up in a city. But that has to do with other exposures outside of actually what you're eating. And it probably doesn't seem to have any effect, doesn't seem to be due to the diet. It seems to be due to the other exposures that people have just being around those animals and that kind of thing. So we're still stuck with living on a farm as your best bet for preventing future allergies. Oh yes, the question was about medications and whether there are interactions with medication between different allergy medications, and whether one allergy medication for rhinitis is better than another. And the answer to that is kind of complicated. Basically, there are in fact a lot of different medications out there for allergies. They tend to fall into different classes. And among those different classes of treatments, there are some advantages and disadvantages to different ones. Everything that's out there, everything in the world has advantages and disadvantages, right? So, for example, if you look in that antihistamine class, all the different antihistamines out there, there's tons. I mean, most people know about Claritin, Zyrtec, Allegra, Benadryl, but in fact, there are probably close to 40 different antihistamines that are potentially available to take. Those are just the common ones that everybody knows about and that are easy to find in drugstores. So, and they all have trade-offs. For example, Allegra is very good because it has, of all of the antihistamines that are out there, it's the main one that's commonly available that really does not cross the blood-brain barrier at all. So you don't get any of it into your brain, which means that you really don't get any neurologic side effects, mostly sleepiness, right? So Allegra should be good for that. Downside is that you may have to take it to get the best effect of it from it. You may have to take it twice a day. So there's trade-offs, just like with everything. Claritin was actually originally put out there at the dose that's recommended. Was recommended at that dose because it was a small enough dose that it didn't produce sedation, but that meant that they actually lowered the dose specifically to make it less sedating. So if you want it to really work better, you may have to take a little bit more. And of course, but then you'll trade off. You'll have to deal with the sedation. So all of those things have those kinds of. So it is a complicated question. I would say that there isn't necessarily one that's better or worse than others, and I have lots of people on different kinds of combinations. So I think it's just what is important to realize is there really are options out there. The most effective medicine that is out there is the nasal steroid. So in terms of suppressing the inflammation, that's like Omniris, Flonase, Nasonex, Rhinocort, those kinds of medicines. They're topical sprays. They don't have a lot in the way of side effects. They can give you some nose bleeding, especially if you're not using them, sort of like pointing them in the correct direction and applying them correctly. But generally, they don't have too much in the way of side effects. They are the most potent medicines, but they're not always enough for people for a lot of the reasons that I kind of mentioned. And so you do have to stir some of these other medications in. So that brings the question of whether there are interactions. In general, you can use, like, so for example, a nasal steroid and an antihistamine without any interactions. You can use a nasal steroid and Astelin, which is a different kind of nasal spray, without any interactions. But between the classes, there may be some or within the classes, there may be some interactions. For example, you don't want to necessarily take Claritin and Zyrtec, or Claritin and Allegra, because then you're kind of overdosing in that antihistamine pathway without working on some of those other pathways that are responsible for allergy. So in general, it actually, even though it seems a little counterintuitive, it's a little better to be on different kinds of medications than to be overloading one specific pathway. And that's so that's generally the approach that we take is to try and use additional medications, because those will actually block other pathways in the allergy, in the development of the allergy symptoms. The allergy shots are the one thing that you add in there that is a little bit different, because allergy shots are the only thing that change the way your body responds to allergens. And so of all those medications, they're all there to suppress symptoms. The allergy shots actually change the way your body responds. So that is an important distinction, I think, between them as well. The trade-off there is that they're a lot more logistically difficult to manage.
Do they suppress the immune system? The allergy shots?
They don't suppress the immune system. They actually change the way your immune system responds. So I was mentioning, when you get exposed to peanut, your body makes, or peanut's the wrong example here. If you get exposed to a pollen, your body makes an IgE to the pollen. And that IgE is sitting on the mast cell, and it does that whole deal. When you get allergy shots, you force your immune system to make a different kind of response, and it starts making a different kind of antibody called IgG. So it's not that you're actually suppressing the immune reaction. You actually still make a nice, healthy immune reaction to the pollen. And people who get on allergy shots will tell you that, because a lot of times they get some local tenderness and swelling right where they get the shot. You're still making a nice, healthy immune response to that pollen. It's just different. It's not an allergy response. So, yes?
I'm wondering about correlations between the toxins in the air, pesticides, environmental things, in this area specifically. Do you see any research that suggests that if you live in Silicon Valley, there's a greater likelihood of developing allergies than Watsonville, farms, whatever?
So there is that, but most people think that that's related to the hygiene hypothesis question. That if you're living in Watsonville and out on farms, you're more likely to be exposed to those bacteria that help you develop different kinds of immune responses. That said, I did work actually for a while on the Breathmobile when I was down in Los Angeles, which was a mobile asthma clinic that went down to Long Beach and served the 710 corridor in Long Beach. 710 corridor is the place where all of the shipping from Asia basically enters the United States. Everything that you buy, every television that came from Asia, is driven down that freeway at some point in its lifetime. And so there's a huge amount of air pollution through there. And the whole reason that they funded us to do this mobile clinic there was because they were trying to remediate their impact on that with all the air pollution there. And I will tell you that there was a lot of very, very severe asthma there. And one of the things that was looked at in the UCLA Asthma Center was this question of whether diesel particles in particular, or other kinds of air pollutant particles, can actually act as adjuvants. Adjuvants are things that stimulate your immune system to make particular kinds of responses. So I was telling you, the T cell tells the B cell to make that IgE, right? So how does the T cell know what to tell the B cell? The answer there is actually the adjuvants. So your T cell recognizes the context of what's happening around it in this sort of inflammatory milieu, and it says, okay, if it looks like this, then I need to make this kind of response. And those adjuvants, including diesel exhaust particles, may help promote the development of that Th2 allergic kind of response instead of a different, more functional kind of immune response. The question is whether you should drink unpasteurized milk or not. In general, it's better for you to stay with pasteurized milk for the infectious question. We have the cattle in the United States is better protected against a lot of diseases than other things, but it is still better to have pasteurized milk. You're running the risk, when you drink raw milk, you are running a risk of exposing yourself to the bacteria that are definitely still in that milk. It's much better for making cheeses because you want those bacteria there, but it's not so good for drinking raw. If particularly if you have any immune deficiency or any question about whether your ability to fight off infections is adequate. So the question is whether nasal steroids are safe for children. And the reason there's disagreement is the following. If you look at, nasal steroids are forms of things like prednisone. If you take prednisone, which is an oral steroid that you take and it's absorbed into your body and it goes throughout your body and works on all the tissues in your body. If you take that, you have very significant side effects as a child, if you take it for any significant length of time. It has effects on bone, has effects on growth, it has effects on blood pressure, weight gain, lots of different significant side effects. There are some cases where we have to use it for kids for specific diseases, not so much allergy even, but really severe asthma, autoimmune diseases, those sorts of things. But the nasal steroids, almost none of the nasal steroid is actually absorbed. It goes into your nose, it sits on the surface. It's almost like when you apply a cream to your skin, very little is actually absorbed. There is a little bit that gets absorbed, but that stuff that is absorbed goes first through your liver, and your liver, the design of those steroids was such that it was designed so that your liver would basically inactivate it as soon as it was absorbed. That means that there's very little active steroid that actually gets into the body. That said, if you have a very young child and you're using a very large amount of those topical steroids, including the nasal steroids, you can start to see some effects like that. It usually has to be quite a significant amount, though. For kids who are on asthma, who have asthma and are inhaling steroids to prevent their asthma, they can get a little bit of a slowdown in their growth initially. They don't get the other side effects of steroids, but they can get a little bit of slowdown in their growth. That slowdown in growth does not last, though, and they ultimately catch up. And they have, because they catch up and because uncontrolled asthma also restricts your growth, it's very controversial about whether, how significant that little slowdown in growth really is. It does seem to be consistent across studies, and so I think it probably is real. A little bit of slowdown in growth velocity, but weighed against what asthma can do to you, it's actually much more important to take it than not. So by and large, it's been really hard to find any real significant effects with topical steroids, even for fairly young children. That said, if you really drive the dose up high enough, you can start to get some of those effects from people, but you have to be pretty aggressive to do that, and it's not going to happen at the typical doses.
So small doses, in your professional opinion, is okay as long as it's not heavy.
Yes,
doses.
and I do use that. You do also want to be sure that you're using it appropriately and not using it for things that don't matter or are caused by something where the steroid would not be helpful. So you do want to use some judgment too, because you don't want to use medicine you don't have to use for any reason. The question is how, if you had been on allergy shots for 2 years and then stopped, is it worth trying to pick it up again, or should you just stop and call it good? And so the studies that have been done of the allergy shots show that most people will have a permanent change by about 3 years, and then even more will have a permanent change by 5 years. So 2 years, it may not quite be enough, and he might sort of slip back and start to have some more sensitivity again. So in general, people do recommend that you go out at least 3 years to really try and get that permanent change. Now, I can't say that that wouldn't happen for him, and maybe they're probably just like there's more people at 5 years than there are at 3. There's probably still a few people there at 2 years, but but I can't say for certain whether that's going to be him or not. So again, the question is whether stress levels can affect your symptoms with hay fever and that. There's probably a lot of factors that go into it. I think that you have some. People certainly do say that stress affects their perception of their allergies, and people who are really stressed out, they tend to be pretty miserable. Now, it's probably kind of a combination of things. There are definitely some interactions between the neurologic system and the immune system, and so there's potentially some alterations in inflammation that could happen that way. That's not very well understood, but it certainly is plausible. Also, people who are very stressed out tend to perceive their symptoms more. That's very clearly demonstrated as well too. If you are miserable at work and having an awful time at home, you will feel your allergic rhinitis a lot more, even if it's sort of at the same general level of symptoms. Same thing kind of happens with pain as well. So that's another factor that might be contributing to that as well. So I think that probably is true, and there are probably multiple things that contribute to it. There are some research studies that are actually going on too, and they're looking at that question of the connection between the neuroendocrine system and the immunology and the immune system in general. But they are probably a ways out from giving us any real informative information.
That's probably the last question for tonight. Thank you so
Okay.
much, Dr.
Thank you.